before we record.
All right. It looks like we know just about everyone here in the meeting today. So we won't do announcements or just meet and greets. If you want to, if you're new and I've missed you, just put your name in the chat box and where you come from. And so Dr. Lawrence is going to be talking with us about recurrent fevers. And I know this is a topic that everybody just loves. And because it's a challenge in the clinic all the time. So before we get started, I wanted to let you guys know I updated last meeting, but not sure if everyone's here. We're gonna put this on a YouTube video. So if you guys want to, um, just refer to the information later, it is at the YouTube channel at I Echo Peppy. And if you want to email us, it's info echopi@gmail.com. I will put everything in the chat box so you guys will be able to have that information. And then I'm just going to turn the floor over to Monica and let her get started.
Awesome. Thank you so much, Angie. And thank you everyone for being here. I tried to make this super practical. It's about kind of patients with recurrent fevers, which is something that I know I see quite a bit. I imagine folks kind of on the front lines in primary care clinics see it even more than me. So hopefully this will be relevant to many of you. What do we do when we get a patient who comes in for evaluation for recurrent fevers? Again, I think this is a patient we've all met. How are we going to think about this patient? How are we going to triage whether this patient needs workup or not? So here's kind of the flow chart, and we're going to walk through it. So when I look at a kid who has recurrent fevers, the first step, which sounds pretty basic, is verify that it is in fact a fever. So kind of up here at the top. Questions. Are these really fevers? You'd be surprised. Patients will tell me, I don't actually take their temperature. I just feel their forehead. And if they feel hot, I call it a fever. Or it's a fever for her. Like she normally runs 97. And so 98 is a fever for her. Everyone's laughing. We've all heard that before. So like, what is that? What are they saying when they say fever? What happens in response to medications, right? And are they giving an appropriate dose of an antipyretic? And what treatments have they tried in the past and did they work, right? And that can give you a clue as to whether it was infectious or not. If antibiotics didn't help and the fever persisted, that is a sign maybe it wasn't a bacterial infection. Or if it got better on its own within a day or two. These are kind of clues that may give you some ideas about cause. Some other key questions, just getting into the history, and then I'll talk about why these are important in a minute, but you really want to get a good history of these fevers. When did these start? Did they just start a few months ago, a few weeks ago? Have they been going on since this child was born? When they come, do they last a day, several days, weeks on end? And is there any kind of pattern to these fevers that they can discern? And then I have a whole kind of smart phrase for those of you who are Epic users, but you can kind of have a mental checklist of things that go with fevers and a lot of our fever syndromes. So kind of going head to toe in the head and neck, oral ulcers, pharyngitis, adenitis, and then arthritis, belly pain, emesis, diarrhea, and then, conjunctivitis. But those are kind of the main ones I'm asking about. Anything else concerning systemically, right? Is this child failing to thrive? Is this child losing milestones or failing to meet milestones? And then how's the kid look in between? Are they completely normal in between, or do they look sick all the time with these flares? And those are all kind of clues, and we'll go through why those are all important questions in a minute. And then obviously, is anyone sick at the same time? And does anyone else in the family have this kind of same history? So the first kind of branch point in my mind, once I've confirmed that this is a real fever taken with an actual thermometer, representing an actual number greater than norm, is is this child well between episodes? And are these child's labs normal between episodes? So that's important. So not when they're sick, because no matter what, if your fevers are due to almost anything, you would expect someone to have elevated inflammatory markers and elevated white count when they're sick. So those labs are less helpful to me. What's most helpful to me is when they're well, what do their labs look like? If they are not normal when they are well, then you need to be thinking about more non-immunologic, so things like rheumatologic, like SGIA or oncologic causes. So, yeah. And so again, I usually check a high sensitivity CRP, a SED rate, and a CBC diff. A regular CRP would be just fine too. Okay. If you've convinced yourself that they look fine between episodes and that they have normal inflammatory markers in between episodes, then you're sort of down the pathway of most of our patients. And so then the very first one, which I didn't have on here, but I want to spend most of my time talking about because it's what most of them have, is not a non-inflammatory syndrome. But as part of kind of the initial workup, one thing that I say is to take a fever diary. So this is the stage where I start to recommend it. I've taken a history, I've done some basic labs, and then I have the parents do the work of record their temperatures every single day in the morning because everyone's fever gets higher and everyone's temperature spikes in the evening. Use the same thermometer, use the same site, and then write down any of those symptoms that I asked about. You can have, if you see enough of these patients, a handout like check off symptoms, or you can just tell them what you're looking for. And they can just write it on a piece of paper. It doesn't have to be anything fancy. All right. 99% of these kids, and I see these kids every single day in my clinic, do not have any underlying syndrome. They're having recurrent viral illnesses. But how are you going to convince their families of that this is within the realm of non-concerning? Well, first, you're going to ask for clues, right? Are there people sick? Are they in daycare? Do they have localizing symptoms? That's kind of obvious. I like to pull up this study all the time. I don't know how many of you guys have seen this study. It's called the Big Love Study. Has anyone seen this study? No? Okay, so Big Love, pro tip, don't just Google Big Love. You get like kind of scary search results. But Google Big Love Study. Big Love stands for Better Identification of Germs, Longitudinal Viral Epidemiology Study. And this is a really cool study. So they took 26 households, which made up 108 individuals, so big families. And then every single week, they swabbed their noses, regardless of whether they were having symptoms. And then they recorded symptom diaries at the same time. And then they did a PCR on that nose swab for like a respiratory viral panel. And then it's shocking. So this is the graph, the next page that I like, or next slide that I like to show people. So look up here at the top. If you are under 5 and you have a household, so if you're under 5, period, 50% of the time you have a virus in your nose, right? So young children are sick all the time. And it goes up even kind of exponentially depending on how big your household is. And what I remind people is that daycare becomes your household. So if you're in a standard toddler classroom with 4 or 5 other children, it's possible that you have a positive viral swab 87% of the weeks of a year. That's literally all the time. So you are actually always sick. And these are normal children without a known immune deficiency. And more importantly, they're not always going to be symptomatic in terms of cold symptoms when they have those positive viral swabs. So depending on the virus, they may be anywhere from 0 to 100% symptomatic with it. So they may say, well, no one else is in the house that's sick. No one else in the classroom is sick. Those children may be asymptomatically infected and shedding. And then your child may be one of the ones that does get sick, right? So depending on the individual, you may not have all the same symptoms. And then a separate study that I like to remind them of is this one, which is if you have kids in the ED with a fever without an obvious source, right? What is the cause of their fever? This is a really cool study. So they took three groups of kids who had a fever with unknown source. 75 of them had a definite or probable bacterial infection, or were just completely afebrile, just pre-op patients. And they did both viral swabs of their noses and their blood PCRs. And in the kids without an obvious source of infection, they found that 76% of them had a virus detected, right? And most importantly, only a third of them, you could only get it by blood PCR, which we don't do blood PCRs on febrile children in the outpatient setting typically. So if your child is coming in with a fever, most likely it's due to a virus, and you may not have symptoms, and you may not be able to pick it up even on a respiratory viral swab, but it's still a virus. So again, the most common cause of recurrent fevers in young children, take home point, is viruses. And it's normal, and it's not a syndrome. So I spend most of my time going over this with families. So I will just give you those two studies to have in your back pockets. Okay. If you are convinced that you are not dealing with recurrent viral infections, or if you need to still convince the family that that is not an underlying syndrome, you may choose to do more workup. So at that point, then, what you're looking at is age of onset, and then periodicity and pattern of fevers. That's why I asked you to get the fever diary going, was because that's what's going to really help you to sort out where to go from here. So the first question, remember, that I asked you to ask at the very beginning was, when did this start? If it was neonatal onset, less than 1 year, you have very few options for what it could be. One is cyclic neutropenia, and one is hyper IgD syndrome. Oh, sorry, let me go back. If it is over a year, then your options become a little bit broader. And really the major branch point comes down to whether the fevers are regular or irregular and how long they last. So what do I mean by regular? I mean every single 3 weeks or 4 weeks, I'll have families say, I can literally set my calendar alarm. I will know my child will have a fever in 4 weeks, and another fever 4 weeks after that, and another fever 4 weeks after that. They are like clockwork. Every child is unique. Some families, it may be 3 weeks. Some families, it may be, or some patients, it may be 6 weeks, but either way, it's regularly occurring. If it's irregular and you're convinced it's not viral, then there are some periodic fever syndromes that you need to be thinking about, but that's really your big branch points. When did it start, and are they regular or irregular? So I wanted to spend the first part of the time talking about the one that you're most likely going to see. And that's PFAPA. That falls into the older onset regular, right? So there, P stands for periodic, and then F for fever. So periodic is set your clock by at periodic typically. The A is for aphthous meaning oral ulcers. P is for pharyngitis, so sore throat. Often these are kids who keep getting swabbed with concern for strep throat, and it may come back negative. It may come back positive, depending on if they're a carrier or not. And then adenitis, they get this cervical adenitis. This typically it's not a neonatal onset. It's age is around 2 to 3 years usually when it happens. Again, the periodicity is regular. Occasionally, though, you can see other symptoms, and patients may not have all the symptoms each time. So it's not quite as straightforward sometimes that if you're starting to hear they get a sore throat, their glands get swollen, they may get some ulcers most of the time, but not all the time, but I can always know when it's going to happen. That's probably a PFAPA patient. Importantly, this is a clinical diagnosis, so you don't need any genetic testing. You don't need an immunologist to tell you this is a diagnosis. You don't need a referral. You don't need anything other than a primary care office can do. You can make this diagnosis on your own. We'll talk about treatment at the end, but the treatment is something that's very well within kind of the scope of what you could prescribe. The other one I want you to be, the other disorders I'm about to tell you about, I want you to be aware of, but I'm kind of gloss through them because they're less common. They're very, very rare, all of the rest of these. So, and truthfully, the details get really murky, even for those of us who do it every day, about the differences between each of them. So I put these slides here so that you could refer back. I'll go through them quickly. But again, knowing exactly which one it is really about pattern recognition and matching. So you're going to take a good history. You're going to get a good periodicity from your fever diary, and then you're going to kind of look at that slide and reference back as to which one you think it might be. So hyper IgD syndrome is one of the ones you can think about that starts early. The cardinal feature for this one is abdominal pain. But otherwise, there's some overlap, right? So big lymph nodes, fevers. But the abdominal pain and emesis is really a cardinal feature, and then the young age of onset. And in this case, there is genetic testing that can be helpful, and some additional lab findings. FMF, or familial Mediterranean fever, again, one that you may have heard of, but tends to be more rare. This one also has abdominal pain, but arthritis is another feature, which isn't really a feature of hyper IgD syndrome. And then this really interesting, like erysipelas-like rash that tends to occur. These kids tend to be a little bit later presentation than hyper IgD syndrome. And again, genetic testing can be done. All right. Again, I know I'm going quickly through this. I don't expect you to memorize these. I just want you to have a passing understanding that these are all out there. There's something called TRAPS. These ones are like weeks long of fever, days to weeks, so really different story. But again, abdominal pain. And then here you see some more myalgias and arthralgias and conjunctivitis, periorbital edema. So a little bit different symptom complex. Again, genetic testing is available. That's kind of a common theme for everything other than PFAPA. These can be genetically diagnosed and confirmed in many cases. And then last but not least is cyclic neutropenia. This one is a really tough diagnosis to make because the fevers occur after the neutropenia occurs. So if you try to get labs when a child is febrile, you're going to miss the neutropenia. And so what you end up having to do is do repeated CBCs multiple times per week, because the neutropenia usually lasts a few days, and then the fevers cycle, typically every few weeks. And so again, if you just do a CBC when they're febrile, you may miss the neutropenia. Yeah. So this is, again, it's a tough thing for parents to have to go through because it's multiple times a week blood draws for many weeks in a row to kind of try to tease out this diagnosis. All right, lots of other ones. I'm not going to go through and bore you guys with all of these. I just want you to be peripherally aware of them. And again, the hallmark though is going to be to do your branch points and then consult those kinds of lists. So here's where I think might be a little bit helpful to you. We went through those, through these. So I've put in here lots of tables. Again, not to go over today, but for when you reference this talk, hopefully, if you have a patient in clinic, of how are you, once you have your fever diary in front of you, going to sort what your differential should be. You're going to look at the frequency of the episodes and the periodicity of it, meaning how often the fever is going, and you're going to try to match it up there. You're going to look at the duration when they get a fever. How long do the fevers last? It varies by underlying disorder. You're going to look at associated symptoms, right? So I highlighted those in red there. And I have a nice little chart for you to kind of go through which disorders have which findings. So again, it's just pattern matching. I will tell you though, patients with autoinflammatory syndromes and periodic fever syndromes don't read the textbook very often, so they never actually perfectly fit with this. So this is all like well and good, but it never is actually perfect. But hopefully this will get you a good start. All right. How are you going to approach these kids if you think you're dealing with one of these more common ones? If you think they have recurrent viral infections, you're just going to reassure them. This will take more time than any of the other treatments that you're going to prescribe because no one will believe you, but you're going to do the best you can, show them the big love study, show them the picture, reassure, 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 talk to them about what a subclinical infection means, talk to them about not having the ability to detect every virus under the sun. Do the best you can. PFAPA, remember I told you it's a clinical diagnosis made by the classic findings of periodic fever, aphthostomatitis, pharyngitis, and adenitis. But you can't do any kind of confirmatory testing other than you can trial treating. And if the treatment works, that's all the proof that you need. So how do you treat these people? You're going to give them a single dose of steroids and make it a good dose. So it says 0.5 to 2, but I like to go 1 to 2, like go big or go home. Give them a single dose of steroid the minute they get sick with a fever. And it has to be one of their normal fever episodes, not like they're feeling sick otherwise with other symptoms, one of their classic fever episodes. Give them one single dose of prednisolone. And if the fever goes away completely, fever resolves within an hour, that's your proof that that was PFAPA. And then in that case, you can then decide, you can either reassure the family that's what it is. You're likely to outgrow it. Most kids outgrow by school age. It can be a little bit later, and there's no long lasting harm to having these fevers. So you can just reassure and not treat. They can continue abortive therapy with steroids and with every fever episode if they want. Eventually, that adds up to a decent amount of steroid exposure. So I usually tell families don't treat every episode if you don't have to. Like if you're going to a beach vacation and it would be inconvenient to have a fever and have them feel puny at the beach, then maybe that's a good time to use the steroids. But otherwise, if you can just write it out, that might be better. Or you can use either cimetidine or colchicine for prophylaxis of episodes. Those are anti-inflammatories. They both come as liquids and as pills, although the liquids are outlandishly expensive. So I usually just crush or break the pills for cost reasons. They can get their tonsils out. It helps in some cases, but it's not well understood. I usually don't like to do it. I think doing a surgery for a self-limited benign condition is probably more than what I would recommend, but it's not wrong. And many ENTs will take tonsils out for this indication. But again, even without their tonsils taken out, they will get better with time on their own. I put this in here for you to see what the doses are and what the side effects are so that you can reference back for all of the drugs that I just mentioned. For cyclic neutropenia, the very specific treatment is to juice the neutrophils with G-CSF. You'll probably do that in conjunction with a hematologist. And then for all of the rest of the syndromes, the treatment is the same. Steroids, TNF inhibitors, and then anti-inflammatory, anti-inflammasome targeted therapies, which there are a variety of. Those are biologics, which probably would want to be prescribed in conjunction with a rheumatologist or an immunologist, but certainly you could. Things like anakinra or canakinumab are options for you. I will reference you to this lovely review article that is in our Journal of Allergy and Clinical Immunology and Practice. And you can read all about it. They have lots of lovely tables in there if you need more. Otherwise, I will just say my work here is done. It's obviously completely straightforward. You all know everything you need to know about recurrent fever syndromes. I'll stop there, and I left 5 minutes if people have questions. That's it.
Does anyone have any questions? Okay, so
I
in
do, sorry.
go ahead.
I do have a question. Thank you so much for the talk. It was really great. So my question is, considering that there are some incidents of false positives, for
Mhm.
example, people that have been um, sick because of COVID or rhinovirus, after some days, they still tested positive for it,
Mm.
but they're not sick because of that. So in case of children, um, I was wondering how accurate the diagnosis can be in terms of saying, okay, this children might be sick because of PID, not because of having COVID, but still tested positive for COVID. Like, how can we distinguish these differences? Yeah.
Yeah, that's a great point, Roxana. You're absolutely right. You can pick up lots of things on viral swabs and PCRs that are latent or kind of no longer actively replicating, right? So you don't ever have truly proof. But it's the longitudinal information, right? It's the same concept of how do you know someone's a strep throat carrier versus infected, right? It's the whole clinical picture over time that evolves. But I agree, in the moment for each individual person, it's going to be a challenge
Yeah.
to sort out.
Thank you. Thank you.
Mhm.
Dr. Lawrence, wonderful talk. I have to ask you a question for the
Oh boy,
group, but
Dr. Ryder, please do.
seriously, Monica, thank you so much. Um, how early do you pull the trigger on genetic testing for periodic fever syndromes? I mean, certainly, and you outlined an incredible and I think very really appropriate, thoughtful methodology for thinking through this. But given that all but PFAPA can be diagnosed via genetic testing, how early on when you get a patient, we say, this is bona fide real fevers, and there seems to be some periodicity to it. Do you send to genetic testing?
Yeah, and it's a great question. Thank you for asking it. In my clinic, I send it pretty early because I'm comfortable sending it and I have a genetic counselor that works with me. And so I feel like it's accessible. I would think though, I mean, the reality is the sensitivity is not great. Our autoinflammatory syndrome panel has 150 genes. There's probably 1,500, so we're probably not even catching them all. I would say of all of the autoinflammatory syndrome panels I've sent, which has been in the hundreds, I probably picked up 2 or 3 that were positive. Is that your hit rate too, or am I just unlucky?
No, I agree with you. I mean, I've had either the PFAPA patients or I've had
Yeah,
patients that have bona fide periodic fever syndrome, autoinflammatory disease, who even respond to anti-IL-1 therapy, but they don't have a genetic hit on the panel.
exactly. Yeah.
So, yeah, I think it's a great point that you raise.
Yeah. So I think you're absolutely you're fine to not send the genetics. It is the take home point for our primary care folks out there is that it rarely changes the management. Occasionally it does. I saw a little girl the other day with congenital neutropenia and persistently positive inflammatory markers, and we ended up with a diagnosis, and we are having the ability to give her targeted therapies for it. So occasionally you hit a home run with it, but it's rare.
Do we have any other questions? Okay, so and we're a little bit later today. We'll have the slideshow up, so you guys will be able to reference those medications and the articles, and probably be up by tomorrow at the latest. But go ahead and refer back. I also put in the chat our YouTube channel, and I put in our email. So feel free to contact us, and we want to know how we're doing. And if you have a specific patient that's just in the back of your mind that you just want to know more about, want to know if you are taking the right steps, feel free to email us and let us know. Make sure the information is de-identified, but we would love to help you out. And then there's also a discussion board on the IACA website, so you're able to just chat with us periodically during the week if needed. And I thank you all for attending.
All right. Thanks, everybody. Have a great
Thanks, everyone.
day.
Bye.